All right, Ethan, why don't you
Sure.
get us started here?
So today I have five aliquots, and in the fifth aliquot, I will reveal the final diagnosis. So today we have a 85-year-old female coming in for jaundice. So for the past 2 weeks prior to the visit to ER, the patient has complained of mild intermittent abdominal pain, nausea, loss of appetite, and weight loss. And 5 days ago, the patient's family also noted yellowing of her eyes and skin, along with cola-colored urine. And due to persistence of the symptoms, and they visit the hospital. And that's the first aliquot.
All right, I can get us started and then pass the mic. As David mentioned, Jack, he is a jaundice expert, so I'm excited to hear Jack's thoughts. So we have an 85-year-old woman who's like coming in with jaundice. Oftentimes when we hear jaundice, we translate it in to hyperbilirubinemia as a lab finding. One of my favorite fun facts in medicine is that, with jaundice, with hyperkeratinemia, you can also get yellowing of the skin, and the eyes is where, it's truly jaundice when you have sclera icterus. So, and as Ethan have mentioned, the patient has yellowness of the eyes. So when it comes to jaundice, oftentimes the branch point for hyperbilirubinemia are we dealing with a direct or an indirect process, thinking that it is I would be prioritizing a hepatobiliary issue, mostly as a lot of the common etiologies of jaundice that we see are hepatobiliary. I always like, you guys know me, I always like to think about no misdiagnosis. So whenever I see jaundice, one of the things that has a lot of more mortality and morbidity associated with it is cholangitis. So that is one thing that it's high on my list of things to think about. And also the other thing is hemolysis. Oftentimes with hemolysis, a bilirubin might not get high enough to have the certain degree of jaundice that we see here. And oftentimes, with direct hyperbilirubinemia, we can get a higher elevation in bilirubin. So I'm going to pass the mic with that framework of direct and indirect tends to be the most helpful, and then pass on to Jack to layer on the other symptoms patient is presenting.
Awesome. Thanks so much, Sharmin. No, I think you really kicked us off perfectly there. I think if we look at sort of where, or if we use the framework that Sharmin just elaborated, we can see that the direct hyperbilirubinemia diseases, the center of gravity of the syndrome tends to be below the diaphragm in the intra-abdominal cavity, whereas the indirect hyperbilirubinemias tend to be more systemic in nature or relatively bland in terms of their presentation. And so the fact that we have action in the intra-abdominal cavity from this initial HPI that Ethan gave us, combined with what seems like maybe relatively dense jaundice, as Sharmin mentioned, all increase the probability of a direct hyperbilirubinemia and some sort of intra-abdominal or pancreatic hepatobiliary disease, right? We have nausea, some weight loss, some loss of appetite, and then also what sounds like initially painless jaundice that has now progressed to having pain, because it sounds like the pain may be crescendoing in nature. And so, as Sharmin mentioned, cholangitis can be a disease that develops in and of itself, but it can also be a disease that develops as a complication of hepatobiliary obstruction. And so, recognizing that both of those possibilities, either a painless jaundice disease, a painful jaundice disease like cholangitis, or both, are certainly in play here. So I think from there, right, we'll sort of use the fact that our attention is tuned to the abdominal cavity to look for certain exam findings that may help us. For the pancreatic hepatobiliary causes of jaundice, they can be from intrahepatic cholestasis or extrahepatic biliary tract obstruction. And we can use some of the exam findings that we see to help clue us into that. For example, if we see signs of portal hypertension, that may make it more likely that this person has an intrahepatic cholestatic disease that's causing both hepatic fibrosis and intrahepatic cholestasis. Whereas if we see no signs of portal hypertension on exam, that may make us move outside of the hepatobiliary system. I should say, sorry, outside of the liver. All right, Ethan, take us forward.
So she was recently admitted 4 weeks ago for hypotension with coffee ground emesis, during which a EGD was arranged, which showed two non-bleeding ulcers with gastritis. And during that stay, after discharge, patient had no subjective complaints, and she had also had a repeated endoscopy 2 weeks ago, which was unremarkable. On her past medical history, she had hypertension, type 2 DM, heart failure, glaucoma, and hyperlipidemia. And on her medication list, she was taking amlodipine, hydralazine, latanoprost drops, robustatin, sucralfate, and Senna. Family history was non-significant. She had no prior surgical history and no known allergies. And that's the end of second ELCOT.
All right. So it sounds like the primary piece of data that we've gotten so far is we have this sort of recent background finding of a recent upper GI bleed in coffee ground emesis. And I will say, if we just think about how we map on a recent GI bleed to jaundice in general, I think we certainly can think about what we had talked about before, which is sequelae of cirrhosis and portal hypertension. But the EGD findings here don't map on perfectly with that. And so I think we have to ask ourselves, are there any diseases that can cause ulcers in the esophagus and the stomach and lead to the development of jaundice or intrahepatic cholestasis or biliary tract obstruction? And I'm honestly struggling to draw a straight line between those right now. So I think initially what I'm doing is I'm sort of holding these two diseases separately. There's many reasons that people can develop an upper GI bleed, and those reasons are oftentimes separate than the reasons that someone may become jaundiced. Because the clear branch point between those, I would expect to see things like esophageal varices or gastric varices or portal hypertensive gastropathy on the EGD. So I'm honestly not sure what to make of the recent upper GI bleed right now. What about you, Sharmin?
Yeah, no, I agree with you. I'm having a hard time drawing a straight line. The couple of like question that just comes to my mind is just like how sick this patient was. So when he came in with hypotension, was it hemorrhagic shock? Are we now dealing with like sequela of that? Oftentimes, we think more about like elevated ALT, AST elevation, and not as much jaundice as a sequel of that. And the other one that I was wondering about is like where that ulcers were. Are they, if they were anywhere close, like to ample of water, as it's healing, can it sort of cause any obstruction physiology, or is it interfering with the passage of bile and stones, perhaps, that is like now causing a more obstructive pattern? Again, this is just hypothesis. I've actually never seen that in real life, but thinking about like not just the ulcer itself, but the consequences of ulcers, whether it's like hypertension, location of these ulcers that may relate, or are they just completely separated from each other? What do you how does that sound to you, Jack?
I love it. I think that's a brilliant hypothesis. Yeah. And then just like looking through the past medical history and the meds, I can't say that there's anything there that is like really modifying how to think about the jaundice. One thing that we can see sometimes is it would be interesting to know what the time course and onset of her type 2 diabetes was. My guess is that it's very, very long standing. In certain circumstances, type 2 diabetes can herald or be the canary in the coal mine for a developing pancreatic cancer. And so if this was a recent diagnosis of type 2 diabetes, that might, in somebody who otherwise doesn't have many metabolic risk factors, that might be information for us to think, oh, maybe there was something brewing in the pancreas that hasn't risen to the level of radiographic detection, but has risen to the level of pathophysiologic detection. The mechanism of that is actually interesting. I learned it from some of the oncologists here recently. What I initially thought was, I was like, oh, pancreatic cancers destroy the pancreas and lead to problems with insulin secretion, but it's actually much more of a sort of paraneoplastic effect where the developing cancer induces insulin resistance in the body. And so if this, right, most likely this is long-standing type 2 diabetes if we just look at the base rate. But if this was diagnosed a couple of months ago in someone who's, for example, losing weight recently, that may cue our attention to say, oh, we may take the advanced imaging findings further to really make sure that we falsify the possibility of a pancreatic mass, because that is I wouldn't say common, but not infrequent cause of an elderly person with new onset jaundice.
Yeah, I totally agree with that. I'm thinking about like neuroendocrine hormones being another possibility that can link the ulcers and possibly mass effect in the biliary tract that can cause jaundice. That being said, I love what you mentioned in the beginning too, Jack, is that while we always like want to find links as to how these relate to each other, gastric ulcers, not very uncommon, common etiologies from alcohol to NSAIDs. So the other thing that would be illuminating is to think about like, what was it attributed to? Did the patient was having a lot of pain, used a lot of NSAIDs, or did, they didn't have a really good, like H. pylori was a negative. So I think like gaining some more understanding of like what was the etiology of gastric ulcers, and they might just not be related, and like holding that in your reasoning process, both of those. So kind of the Venn diagrams, as we like to think about, like, oh, are these two separate processes? And then also thinking about how they can potentially be linked together. And the other point that I always like to make with medications are like, especially once we get the labs and we see the pattern a little bit better, medication side effect, medication side effect, medication side effect is a big one to think about. None of them jump out to me, but I always like to run it, especially if it's a cholestatic pattern of injury and we don't really seek duct dilatation. One of the most common causes of is drug-induced liver injury that can cause cholestatic pattern. But oftentimes like you see that with like instead of like chemotherapy drugs, again, not this patient, but just always a reminder to not forget about medication lists. All right, then back to you.
So on to the physical examination. She was afebrile, pulse was 98, respiratory rate was 18, blood pressure was 114/70. And the patient was not in distress. On her head and neck exam, we can see icteric sclera and yellowish skin. Heart and chest exam was both unremarkable. And neural exam she was alert and oriented ×4, cranial nerve was normal, and normal motor and sensory functions. And I also give the initial labs. White count was 10.17, hemoglobin level was 9.2 with a hematocrit of 26.4. MCV was 91, RDW was 19.4, platelet was 371, INR was 1.5. BUN was 9, creatinine was 0.47, sodium was 128, potassium level was 3, and chloride was 90. Yeah.
All right. I'll maybe take the exam and then pass the mic to Jack to think about the initial labs. So the vital signs, a little bit of sigh of relief. The patient is not febrile, which is a good sign, and she's hemodynamically stable. Again, always with blood pressure and everything, it's good to know the trends and patient's baseline to make sure they're not relatively hypotensive. In terms of the exam, it just verifies that we are dealing, the problem is jaundice with the icterus. And sometimes like exam, what you don't find is also helpful. As Jack mentioned, there's about cirrhosis. There is no exam finding that is suggestive of cirrhosis. With cirrhosis in particular, you want to look for signs of hyperestrogenemia. That tends to be more specific. So your gynecomastia, splenomegaly, which we don't see in this patient. It seems like I didn't hear any particular tenderness of palpation in the right upper quadrant or anything on the exam. And the other thing that I was watching out for when Ethan was presenting exam was the neuro exam, and if the patient is altered or not, to think about whenever we think about liver and liver pathology, one thing we want to not miss is acute liver failure. And part of that is, if the patients have altered mental status as well, in addition to the lab findings. So the exam just tells me still the focus probably is intra-abdominal. Thankfully, the patient's stable. I didn't see any evidence of cirrhosis and the patient is not altered. So Jack, what are your thoughts on the labs?
No, to jump into the labs here, I think we see the anemia here. I may have missed this, Ethan. Did you not, or have we not received the liver function tests yet? Or did those come out? Because I think I may have just missed those.
Uh, they will come out in the next alcohol.
Okay, perfect. So just looking at the CBC here, we're met with this new anemia, and we have the possibility of hemolysis on the table here. We've talked a little bit already about how dense jaundice tends to be from hepatobiliary diseases rather than hemolytic diseases, but there is the possibility that sometimes we can see both come together. The fact that this person is anemic in the setting of a recent GI bleed, I think we would prioritize the recent hemorrhage as the most likely driver of the anemia. But I think in the back of my mind here, the thing that I'm wondering is, gosh, like, is it worth just sending the hemolysis labs here, particularly given that we're thinking about hemolysis being on the table? And this is where it would be helpful, Ethan, there's no need to give it to us, but just to sort of narrate out loud, like if we're seeing that her hemoglobin was actually 13 when she was discharged from the hospital, we don't see really any sort of laboratory evidence of severe upper GI bleed or exam evidence. And so we've seen another precipitous drop in her hemoglobin as we have seen the jaundice develop, right? That may certainly cross our threshold to send off the hemolysis studies, but I still think the overwhelming evidence based off of the intra-abdominal symptoms, the degree of jaundice that we're seeing on exam is favoring at least a sort of pancreatic hepatobiliary component to this. But I think it still would be maybe worth at least sending the hemolysis studies because there are rare circumstances where we can see both. Not in this patient, but in individuals who have cirrhosis, they can develop a hemolytic anemia from sort of fragility of the membrane of the red blood cells. And there may be other liver diseases as well that can lead people to develop RBC abnormalities that can predispose the cells to lysing here. And so I think even if all of the momentum is in one side of the jaundice seesaw, we still might want to at least explore the other side here by working up hemolysis. Beyond that, I think I'll hold on further discussion of the labs and turn it back to you, Ethan, to give us some more data.
Sorry, before Ethan, so one other thing about the hemolysis to consider would be I like that, and I think like it's totally fair to send it depending on what the liver chemistry shows. Is that I'm also curious when the patient came in for the EGD for the GI bleed, did they get any blood transfusions? Sometimes you can get delayed transfusion reactions, and I think you can get delayed hemolysis in the setting as well. So that is just like another thing to keep in the back of our mind. All right, Ethan, back to you.
So on the liver function test, AST was 426, ALT was 117, alkaline phosphatase was 621, total bilirubin was 20.8, direct bilirubin was greater than 15, LDH was 358. Blood culture was negative on 2 sets of blood culture, and urine culture was negative as well. So a abdominal CT was done, which showed no evidence of biliary obstruction and contracted gallbladder with some pericholecystic fluid. And then an MRCP was done, which showed normal hepatobiliary system with no filling defect, dilation, or strictures. And on day 3 of admission, patient had 1 episode of altered mental status and improved spontaneously. And a CT head was arranged at that time, which showed no acute changes and persistent chronic mastoiditis. And then we get some follow-up labs, and ANA was negative, and a anti-smooth smooth cell antibody was ordered, which was also negative. And that's it. And the next aliquot will give the final test and the diagnosis.
All right. Well, this is an awesome place to find ourselves. And just to sort of kind of follow the map of the jaundice evaluation, right? We started out saying this seems like it's a pancreatic hepatobiliary disease over hemolysis. We got more and more evidence that put us into the former category of pancreatic hepatobiliary disease. And we said that that could be related to intrahepatic cholestasis or extrahepatic diseases that usually drive biliary obstruction. The hallmark radiographic finding of extrahepatic diseases causing biliary obstruction is going to be a dilated common bile duct seen on CT scan or on MRCP. And that hypothesis has been discovered to be negative here. We don't see any biliary ductal dilation. And so we're now left to say how much, if any, of this patient's jaundice is being contributed to from intrahepatic cholestasis, and how much, if any, is being contributed to from hemolysis. I'll talk briefly about the hemolysis side of it for now, and then turn it back to you, Sharmin, to fill in anything else. But I think if we think about evaluating patients with suspected hemolysis, I want you all to break this down into two sequential steps. The first step is going to be looking for laboratory evidence suggestive of hemolysis. And once we have said, yes, there is lab evidence suggestive of hemolysis, we then move into looking at what the cause of the hemolysis is. And the laboratory signature of hemolysis includes some of the findings that we see here. We want to look for evidence of hyperbilirubinemia. Oh, look at that little AI thumbs up there. We want to look for evidence of hyperbilirubinemia. We want to look for evidence of indirect hyperbilirubinemia, which can sometimes be difficult to ascertain in the setting of coexisting liver disease, which we may be dealing with here. The other things that we look for is a high LDH, a low haptoglobin, which is only usually helpful for confirming the presence because it takes a long time to come back. And then the reticulocyte count can sometimes be another clue. Most hemolytic diseases will have a high reticulocyte count, but the absence of a reticulocytosis by no means excludes hemolysis. There are certain disseminated viral infections or malignancies that can lead to suppression of the bone marrow and thus suppression of a reticulocytosis. So the hallmark signatures that we're looking for is usually indirect hyperbilirubinemia and a high LDH levels. We certainly see hyperbilirubinemia here. Doesn't look like we have the fractionated bili yet, but there probably is some relatively high direct bili given that given that it's above 15. We then also have a very, very high LDH, which could happen for a variety of reasons in addition to hemolysis. And then the other thing that I'm attuning my eyes to right now is the fact that the AST is much, much higher than the ALT here. And an elevated AST can be sometimes a subtle signature for cell lysis anywhere in the body. So rhabdomyolysis can lead to high AST. Hemolysis can lead to AST higher than ALT, as can direct liver injury from, say, alcohol-related diseases like acute alcohol hepatitis. And so in this case here, I think we have compelling evidence to send the hemolysis workup further and look for things like a Coombs test to look for autoimmune hemolysis, a smear to look for microangiopathic hemolysis, and potentially some of the other secondary studies. We may send a retic count here, but I don't think it would change the calculus on the degree of hemolysis. But I think that is one path that we would go down here because we don't have evidence of biliary obstruction. There isn't yet a compelling case for intrahepatic cholestasis, or at least a definitive case for it. And so I think we have to ask ourselves, is there hemolysis in parallel to a potentially another hepatic disease that's leading to intrahepatic cholestasis?
Oh, I loved all of those thoughts. And since Jack beautifully covered other etiologies, I'm going to focus on the cholestatic pattern and thinking like if this is like mostly coming with hepatobiliary, like especially within intrahepatic cholestatic, what other workup would I do at this point? The imaging finding is quite helpful, right? Like we didn't see that elevated, that big CBD duct. It doesn't mean the patient did not have a damage, right? Like one possibility is always a past stone that could have induced all of this. And I think with that, the trend of labs are very helpful. If this is the peak and you see it's coming back down, that is one possibility to think about is like, is it the damage is done? Are we dealing with the complication? And if the patient keeps getting better. The other things to consider is that, with it's the quality of the tests that we get, MRCP is great, CT is great, they're not perfect. So thinking about this is someone that you want to call our GI colleagues and be like, hey, is there any reason just to get an ERCP? or not. Most often they might say like, no, the quality is good enough that we're not concerned about. And at times they might consider an ERCP. The other things to think about is damage to hepatocytes that can cause a cholestatic pattern. And that is like, viral hepatitis. So I don't think it's wrong to send viral etiologies. Shock liver, as we talked about, like if the patient was in hemorrhagic shock and now we're dealing with a delayed consequence of that. Again, the time 2 weeks is a bit long for that to happen. I really love that they send, that you all send ANA and anti-muscle to think about autoimmune hepatitis. Sometimes, especially with drug-induced liver injuries, it can serve as a trigger for beginning of autoimmune hepatitis. And if you're dealing with a drug-induced injury that triggers autoimmune hepatitis, then in those cases, like steroids would be the treatment. So it's really, really important when you think about drug-induced hepatitis that is causing a cholestatic pattern of injury to send autoimmune hepatitis labs. The other thing that, again, to harp back, like making sure we have a good understanding of what medication. Did the patient get any antibiotics? Like, amox notoriously, some of the antibiotics can cause liver injury. So thinking about like, did at any point between the GI bleed to this presentation, did she get any medications that we might be dealing with the consequences of that. And then thinking about, there's some like perineoplastic phenomena that can do it. And then the last but not least category to think about are infiltrative diseases. MRCP notoriously are not really good about picking up infiltrative diseases. So your HCC, which she doesn't have risk factor for, like sarcoid, TB, amyloidosis, those things that can cause infiltration oftentimes are not picked up, but they can cause kind of cholestatic pattern of injury. So I think in terms of like next step, I'm curious to see what reveal the diagnosis. So I wonder if it's like a serological testing. I'm seeing IgG4 being mentioned, that I think is also a great thought here. Any additional thoughts, Jack, from you?
No, I think you outlined that phenomenally well. I think just to sort of play the game of how could we potentially connect all of these things, the gastric ulcers, the hemolysis, the jaundice, the what seems like intrahepatic liver injury, and the high AST here. I think sometimes diseases come up where after we've exhausted a lot of the things that we've thought about, in addition to pursuing the diagnostic test that you mentioned, we sometimes pursue more history taking as well. And I think one of the things that I was thinking about was sort of, as you mentioned, toxin-related liver injury from drugs, also the possibility of alcohol-related liver injury. If this workup that you proposed comes out unrevealing, we may go back to the patient, just ask them, right? Has there been any recent heavy alcohol use that has been happening? Has there potentially been an abrupt withdrawal of alcohol cessation? We've seen a disease on here a couple of times in VMR called Zeev syndrome, which can lead to that, which can be associated in the setting of alcohol-related liver injury. It sits far below all of the other causes of intrahepatic cholestasis that you mentioned, but it is one way to potentially tie these together and also potentially explain the hyponatremia here. Individuals with high amounts of hyperbilirubin and that disease called Zeev syndrome can also get hyperlipidemia in the setting of all this, and that hyperlipidemia can induce like a pseudo hyponatremia that can sometimes do it, or that can sometimes lead to a clinical presentation like this. And so I think that's one of the things where I wouldn't say like we're going to assign that label at this time, but it may prompt us to go back and say, hey, heavy alcohol use can cause gastritis. It can cause gastric ulcers. It can cause liver injury. And if she has recently stopped drinking after all of this unfolded, that can sometimes be the precipitant for the RB, for the red blood cell fragility that then sets off the hemolytic cascade of Zeev syndrome. So that was the only other thought that came up.
I love that. Zeev syndrome is always a good one to think about. That was fantastic, Jack. Ethan, we are so excited to hear what happens next.
So a liver biopsy was done, which showed portal chronic inflammation with lobular activity, lobular cholestasis, foci of hepatocyte necrosis, mild steatosis, and increased periportal fibrosis, which was non-specific, but the pathology department said that it was compatible with a drug-induced liver injury. And after additional history taking and review of recent medications, the patient said that she had taken Augmentin for recent sinusitis, and that compatible with the liver pathology. So the final diagnosis is Augmentin-induced liver injury. Yeah, great discussion. Yeah, amazing.
Drugs, 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 drugs. Yeah, I think yeah, this is even such a great case. And unfortunately, we do see this very commonly. So thank you so much for presenting a case that again is rooted in common presentations and with frameworks that we should all be familiar with. But yeah, I can't, it's like one of the teaching points in medicine that it just real life keeps emphasizing for me is just medications, medications, medications. And as Jack mentions, it's always going back to the patient and asking what meds they've taken, because those antibiotics and especially like chemotherapy, immunotherapy drugs are notorious for causing this cholestatic pattern of liver injury. And again, making sure you send autoimmune hepatitis labs as well, as you all did. Jack, any thoughts?
No, just want to say thank you, Ethan. This was such a fun case, and a really, really great one to get to think through. I was ready for the biliary tract obstruction, so it's a nice variant on that common finding, and yeah, a really awesome case to get to think through. So thank you for presenting it today.
Yeah, thank you both. Yeah, the discussion was great.
Ethan, I love the point that you just put in the chat. Do you want to say that out loud?
Yeah, so some teaching points. So one of them is that drug-induced liver injury could have a delayed presentation. So we have to review the medication list up to the past 3 months. And another clue is actually the CD head finding of the chronic mastoiditis. So like osteitis and mastoiditis and sinusitis share the same respiratory pathogens. So that's another clue. So that patient may have the prior sinusitis, and we should take more history taking. Yeah. So that's two pearls. Yeah.
I love that, Ethan. And to be honest with you, I just completely, my eyes missed the chronic persistent mastoiditis when you were presenting. And that again goes to show the importance of actually reviewing the data points and not anchoring, because I was like so focused in the abdomen. So that was a good reminder for me. Thank you. All right. Vijay, we're so excited to hear your teaching points.
Hi everyone. Thank you, Ethan, for a wonderful case and a brilliant discussion, Jack and Shami. So this was a 85-year-old female presenting with a jaundice. So we had a discussion of how jaundice usually relates as hyperbilirubinemia, but also sometimes keratinemia can be a presentation of yellowish discoloration. Further, we classified hyperbilirubinemia into direct and indirect. And because this patient had abdominal pain for the past 2 weeks, so the diagnosis that not to miss diagnosis were cholangitis and hemolysis that is not to be missed. Further, we classified the direct hyperbilirubinemia into mostly it is intra-abdominal causes, and indirect hyperbilirubinemia usually indicates a systemic cause. And further direct, we classify into an extrahepatic or an intrahepatic. So we can use examination clues, wherein Jack mentioned signs of portal hypertension may indicate a possibility of an intrahepatic cause, which is not present in this patient. And when the abdomen was fairly unremarkable here. So the recent history of recent ulcers and the presence of jaundice, whether we have to unify versus there are two different pathologies, unrelated pathologies were being considered. If you are trying to unify the diagnosis of ulcers with jaundice, possibility of just a toxin like alcohol itself causing an ulcer, jaundice, and some possibility of hemolysis that was revealed in the labs was considered. Apart from that, some pancreatic neoplasm like neuroendocrine tumors was another possibility. And because the patient had type 2 diabetes mellitus, if it was a recent onset process, it could indicate a possibility of a pancreatic neoplasm, which is usually a paraneoplastic process that causes insulin resistance. And in such a patient, the common in this patient, the common examination clues would be to look at the abdomen and to look at the mental status if the patient is going into an acute liver failure, and signs of hyperestrodism for an underlying chronic liver disease. So also here, coming to the labs revealed hemo, uh, mild anemia with a high RDW, so and a high LDH. So the possibility of hemolysis was considered, and there was AST that was more than ALT. So if there is a hemolysis, possibility is we shouldn't be missing the possibility of an advanced cirrhosis that can also have an associated hemolytic signature and delayed transfusion reactions because this patient had a recent upper GI bleed. If there is a hemolysis, the step one would be to look for the evidence of hemolysis in the form of an indirect hyperbilirubinemia and an LDH, and send to look for a haptoglobin which returns at a later point. Our reticulocyte may or may not be elevated because there can be a infectious process that can suppress the bone marrow that can still cause a normal retic. And then we look at the cause of the hemolysis using a direct Coombs test, peripheral smear, and further evaluation for the same. And now coming to the cholestatic pattern. So it is whether intrahepatic versus extrahepatic. So there can be sometimes imaging negative cholestasis, like passed out stone from the common bile duct. And apart from that, common considerations would be a viral hepatitis, shock liver, toxins like alcohol, and predominantly drugs that has to not be missed. And apart from that, infiltrative disease also has to be kept in the back of our mind. And a very important point that was mentioned was drugs can trigger an autoimmune hepatitis and cause positive antibodies for the same, and they are treated usually with steroids for both. And discussion on Zeev syndrome was considered, wherein there is an alcohol that can trigger an hemolytic process and an hyperlipidemia along with it. And it was mentioned in the chat that Ethan mentioned that whenever drug history is taken for most of the drug, we have to review the drug history up to 3 months prior to the point of presentation. And the imaging here also revealed a chronic persistent mastoiditis, wherein sinusitis, otitis, and mastoiditis share a common common pathogens, and that also has to be considered in the back of the mind as the cause of the etiologies. So the final diagnosis revealed was an augmentin-related liver injury. Uh, Thank you for the wonderful piece.
Thank you so much for those teaching points, Vijay. Those were fantastic. A brilliant summary of the case. Anmolpreet, thank you for scribing today. Ethan, thank you again for bringing such a wonderful case for us. And Sharmiz, if you're still there, thanks for a great co-discussion as always. I hope everyone has a great rest of your day and look forward to seeing you next time at VMR. Take care, y'all. Bye, everyone.